Bismillahirrahmanirrahim. Now, starting with the investigations of the thyroid gland and thyrotoxicosis, as we discussed in the previous lectures about the symptoms and the signs of thyrotoxicosis. Now, which investigations are we needing for to go for further treatment? The thyroid profile, which include T3, T4, and TSH. These are the investigation. If you ask for thyroid profile, so you're going to get these three investigations. The T3 and T4 are the thyroid hormone, and the TSH are thyroid stimulating hormone, and they are being controlled by TRH, thyroid releasing hormone, which is released from the hypothalamus. So this is the main thing, that thyroid stimulating hormone, thyroid releasing hormone, and T3, T4, they are basically controlled by negative and positive feedback, and those are the things which are going to monitor about the thyroid diseases. So, if TSH is raised and T3 and T4 are low, so we are going to give externally T3, T4, and if T3 and T4 are raised, so then we are going to start with the antithyroid drug. This we are going to discuss in detail. The other investigation is neck ultrasound. In the neck ultrasound, what two things we can get: whether the lump is whether it is a solitary lump or a multinodular thing, and whether it's a cyst or a solid sort of thing, and it's an adenoma or some cystic swelling. So neck ultrasound is also very helpful. We can see the extension of the thyroid tissue. We can see the lymph nodes with this tissue. And one of the most important investigation is thyroid scan. This is a radioactive scan done with radioactive iodine or technetium 99, and this is the scan in which we get. This is a picture of the thyroid ultrasound. You can see the probe has been put on the neck, and this is the picture of the thyroid scan. And now you can see different things here. Like this is a normal thyroid tissue. There is increased uptake, so it means the patient is having thyrotoxicosis. Like this, if there is a decreased uptake, so it will mean that patient is hypothyroidism, or if it's a normal uptake like a thyroid scan, so it means that patient is thyroid, euthyroid. So with this scan, we can take about the activity of the thyroid gland, whether the thyroid is hyperactive, which is thyrotoxicosis, whether it is hypoactive, which is hypothyroidism, or whether it is euthyroid, that it has generally get enlarged, but it's producing the same level of hormones like a normal thyroid gland. So this is another investigation in which we use technetium 99 scan, in which we use the radioactive iodine to get the radioactive results of the thyroid gland. Coming to the treatment of the thyrotoxicosis, number one is the medical treatment. Antithyroid drug, which is thyrouracil androl, is basically a beta blocker which can control the cardiac symptoms. Antithyroid drugs can be classified into three things. Number one is uh, the medical treatment, in which we can go carbimazole, thyrouracil, and androl. Androl is basically beta blocker, propanolol, and in this thing we give to, as we have mentioned earlier, that there are cardiac manifestation of thyroid gland. So to control those cardiac symptoms like tachycardia, atrial fibrillations, and uh, increase in the heart rate and the pulse pressure. So we give propanolol and the antithyroid drugs, which can include carbimazole and thiazolidine group. Another one as a surgical treatment after preparing the patient for thyroid surgery, making the patient euthyroid initially. Initially, if a patient is thyrotoxic, first step is to make the patient euthyroid by giving antithyroid drug. Once the thyroid desired levels are achieved, then we go for surgical intervention. So the other treatment is subtotal thyroidectomy. There are three types of thyroidectomy. One is subtotal, other one is near total, and the third one is total. In subtotal thyroidectomy, we leave almost 8 gram of thyroid tissue. This is an MCQ question, that in subtotal thyroidectomy, how much gland is being left behind after the removal of thyroid. So it's 8 gram. In near total thyroidectomy, we leave 2 gram of thyroid tissue, and in total thyroidectomy, we take out all the thyroid gland, and that is mainly done for tumor surgeries for the patient of CA thyroid. The third treatment is doing with radioactive iodine. We can give radioactive iodine to ablate the thyroid tissue. Now, this is the clinical method how to go for thyroid examination. As you can see, the doctor is standing behind. You go at the back side. You can just ask the patient to degluate and swallow, and the thyroid moves up when the patient swallow. Why it moves up? Because it is attached with the trachea through pretracheal fascia. This is a frequently asked question in Viva, that why thyroid move up, thyroid gland move up in deglutition or swallowing. So you are just going to say that since the thyroid is attached with trachea through pretracheal fascia, so once the patient swallows, the trachea moves upward, so do the thyroid gland. So this is the bimanual examination of the thyroid gland. We do the palpation from the back side. We ask the patient to swallow. Then we are going to feel each lobe separately. Then we are going to feel the isthmus. This is how we go for feeling of the trachea. As you can see that the trachea is deviated to one side in this picture. The central line is this one, and the trachea is being pushed to the right side. And this is the doctor is feeling the trachea. This is the other two-finger method of feeling the trachea. You can see that the two-finger method, that from both the hands we can feel the alignment of the trachea. This is another method of palpation in which we feel each lobe separately. But in thyroid gland examination, you have to perform the examination from back and from the front. Even from the back, you have to palpate and then come on the front side, and you do the palpation, knowing about the contours, knowing about the borders, the limits, the margin, the surface, and the consistency of the thyroid gland. So they are being detailed. They have to be detailed in detail described on in patients of clinical examination. And even in your BDS class, you get these thyroid patients examination frequently. Rather, for the last many, I have seen for the last many years that the thyroid are being there for the short cases for the BDS students and also for the MBBS students. So this is a very important clinical examination, and every student must have on fingertips the examination details and the examination steps. This is one of the mandatory examinations for any student of a BDS class, or dental class, or MBBS class. This is a patient of thyroid in which the thyroid scan is being done, and you can see here that there is a cold nodule. Now, what is mean by cold, warm, and hot? This what I have told you, that the thyroid scan, we know about the activity of the thyroid gland. So this is one of the picture which we give in your OSPI questions, and in the OSPI the three questions are: number one, describe the investigation. You have to say that this is a investigation of thyroid scan. Number two, what pathology you can see. So you can see that the normal looking thyroid having a cold nodule, and what is the treatment you are going to go for FNAC. And if it's a cold nodule, then we have to go for lobectomy or subtotal thyroidectomy. So this is a cold nodule. Now, what is cold nodule? Cold nodule is the one in which rest of the thyroid is taking normal normal the radioactive substance like technetium or radioiodine, and this nodule is taking not taking any of the radioactive subjects, so it is hypofunctioning sort of thing. If it's a warm nodule, then it means that though there is a nodule, but the activity of the activity in the nodule is the same as compared to rest of the thyroid. And if it's a warm nodule, then it means that the nodule is more hyperactive than rest of the thyroid tissue. These are the three types of nodules, that either it could be cold, warm, or hot nodule. This is again a patient with a cold nodule. This is again a patient with a cold nodule. You do get these sort of investigations, and on your OSPI, and even in your questions, in your SCQ question, you do get these questions, that what is this investigation and how you are going to treat this patient. Uh, Further coming to detail of the thyroid isotope scan. You can see this is a normal scan. This is a hot nodule. You can see it's in red, and this is hyperfunctioning more than rest of the thyroid gland. And this is a cold nodule. It's not taking any radioactive iodine. So I think that now it would be clear to you. Next one is the ultrasound. You can see thyroid right lobe. This is the trachea. This is a nodular thing, and this is the carotid artery. So you can just get an idea that thyroid right lobe is there and pushing the trachea to one side, and these the different nodules in the thyroid. So it's a case of multinodular goiter. Fine needle aspiration cytology is the early investigation which we do go for the cold nodule or a solitary nodule to get an idea about the contents of the nodule. So if it's a malignancy, then we have to deal it accordingly. If it's just a cold nodule or adenoma, then we have to go for lobectomy and hysterectomy. If it's a nodule which is suspicion of tumor, then we have to go for total thyroidectomy. So FNAC in a cold nodule case or a solitary nodule is mandatory to know about exact pathology or pathological features of the thyroid gland.